Welcome. Welcome, everybody. This is the IPA Journal Club. This is actually the 13th Journal Club on Friday, June 13th. So I'm glad we're not superstitious. Uh, so next slide. I'm Jack Drescher. I'm the moderator of the panel. This is my bio, which you probably read when you saw the announcement. Next slide. As I said, this is our 13th Journal Club. All of our journal clubs are available for viewing in an archive, both on the IPA website, as well as IPA has a YouTube channel. Our technical person, Agustin de la Llave, who is in Argentina, will put in the chat the link to the past journal clubs. If you haven't seen them, we have a very stellar cast of speakers in the past as well. And next slide. So one of our two speakers today is Dr. Diana Diamond, PhD, who's a clinical psychologist and psychoanalyst researcher and professor. She's emerita professor in the doctoral program in clinical psychology at the City University of New York and a senior fellow at the Personality Disorders Institute at Weill Cornell Medical College, where she helped develop a psychodynamic approach to treating patients with borderline and narcissistic personality disorders. She's clinical professor at NYU postdoctoral program in psychotherapy and psychoanalysis, as am I, and faculty at the New York Psychoanalytic Institute and Society. She's the author or co-author of 5 books. Recently, the one we're going to be discussing today, Treating Pathological Narcissism with Transference-Focused Psychotherapy. She's an honorary member of the American Psychoanalytic Association and heads its Department of Psychoanalytic Education Research Committee and in private practice in New York City and Sag Harbor. Next slide. Our other guest today is Dr. Frank Yeomans, MD, who's a clinical professor of psychiatry at Weill Cornell Medical College, director of training at the Personality Disorders Institute at Weill Cornell, and an adjunct associate clinical professor of psychiatry at Columbia University. He's president of the International Society for Transference-Focused Psychotherapy, an honorary member of the American Psychoanalytic Association, and past chair of the Group for the Advancement of Psychiatry's Committee on Psychotherapy, where he did a great job and is still there doing a good job. He has authored and co-authored numerous articles and books, including a primer on transference-focused psychotherapy for the borderline patient, psychotherapy for borderline personality, focusing on object relations, and transference-focused psychotherapy for borderline personality, a clinical guide, all co-authored with Dr. John Clarkin and Dr. Otto Kernberg. Next slide. So, just for those of you who are new, have not been here before, the goal of this journal club is to be interactive so that you, the readers, can speak directly with our authors, our guest authors. As mentioned before, the session is being recorded and will be available for viewing on both the IPA website and on the IPA YouTube, usually within a week. If you do not wish to be recorded, please leave your camera off. We like to see your faces, though, so we prefer that they stay on. But if you do not wish to be recorded on camera, I may not call on you to ask a question. Next slide. If you have a question or comment, you can put it in the Q&A section. We don't use the chat function for this meeting, but some people have found that they prefer to use the hand raise function, and so you can do that, and I'll call upon you there. Next slide. When you're called upon, unmute yourself, turn on your video camera if it's not already turned on. And when you're called on, identify yourself, let us know where you're from. Also, please speak slowly and clearly, as not everybody who's joining this group is a native English speaker. And if you haven't downloaded the chapter yet, which you should have, the link to do so is also be posted in the chat. Hopefully you will have read it. It's a great chapter. Next slide. Okay, we're done with these slides. Great. So welcome, everybody. Just so you know, we have over 150 people here today, which is a very good sign of how much people are interested. I'm going to start with the first question, but anybody who wants to raise their hand while Diana and Frank are speaking, please do so. I'm happy to call on people before I go into any of my questions. So could either of you give a brief history of how transference-focused psychotherapy came into being?
Diana and I decided that I'd field that one. we've recently written about that, and it has so much to do with the career of Otto Kernberg that I want to refer some to him. And it's relevant that his trajectory was to be born and have his childhood in Austria, which he had to leave because of fascism. Then spent his adolescent years in Chile, which is very relevant to his analytic formation because he did his psychiatry and psychoanalytic training there, and thus experienced a lot of Kleinian influence, which he brought with him when he came to the United States. And the thing about Kernberg that I want to emphasize that's reflected in transference-focused psychotherapy is that he's always focused on both descriptive psychiatry and psychoanalysis. And in addition to that, the particular psychopathology of personality disorders. In the United States in the 1970s, when he came to the Menninger Foundation, which was like the mother church of psychoanalysis in those days, he was struck by the fact that there are certain kinds of patients who did not respond well to psychoanalysis. In fact, they got worse. These were the days when psychoanalysis had a little bit of a problem with overreach and a kind of attitude of arrogance that it could treat everyone and everything. And psychoanalysis has paid the price for that since, but that's another topic. In any case, you've got these severely ill patients that didn't do well in analysis. And what do? Do you just abandon the methods and look for something else, which others in the field did? Or do you decide you want to continue with the richness of analysis, the conviction that analysis helps people change at the deepest level? And do you modify analytic technique so you can address these patients and help them? And he obviously chose the latter. So TFP is an extension of classical psychoanalysis, although that term is multifaceted these days. It's an extension of analysis to treat a broader population of patients who didn't benefit from analysis. This led to a couple of developments, including research. That's another area in which analysis had shortcomings. Unfortunately, the analytic establishment kind of eschewed research for a long time. When Kernberg and the rest of us, and I'm looking at Diana and along with Diane and me, other people. And Karen Gennaro was privy to some of this at a certain point in her career. We formed a group called the Personality Disorders Institute, and we all decided to take on this challenge. How to treat these patients. We learned from the patients. We learned more about their pathology. We emphasized the Kleinian concepts of splitting, the paranoid schizoid organization, and the depressive organization. We emphasized working in the here and now, but we combined working in the here and now with an attention to what's going on in the patient's external life. So this is going to have a bearing on some other questions that come up, which is how is it similar or different from other forms of analysis? But in any case, we found that we could treat borderline patients, classic borderline patients, quite successfully. We did research that showed that. And I want to emphasize the transference-focused psychotherapy for a long time was not considered a separate therapy. We thought of it, and Kernberg thought of it, as an extension of the analytic method. But when you start to do research, you've got to define your method quite specifically, and you've got to give it a name so that you can study it in research protocols. So we came up with the name transference-focused psychotherapy. We defined it somewhat precisely, but it's still, as I see it, an extension of the analytic method. Moving on, we saw that it helps not only patients with borderline personality disorder, but the whole range of severe personality disorders that we call borderline organization, mainly characterized by the paranoid schizoid Kleinian psychological organization. And that maps on pretty well to the new understanding of personality disorders in the DSM-3 section 5 and then the ICD-11. So what I'm trying to emphasize here is that what was initially a treatment for borderline pathology has expanded to all forms of personality pathology, including what we call subclinical. Eve Talagore wrote a book about extended TFP, which goes beyond our initial target population of patients who had severe personality disorders. I would also say that as we expanded, we wrote a book on TFP for adolescents, the book Diane and I are talking about today, TFP for narcissistic pathology. And I would want to emphasize one last point. Our psychiatric residents said to us, you know, your concepts are helpful throughout psychiatry, not just in individual psychotherapy. Your concepts, in particular, the object relations concepts of internal representations of self and other and how they get played out in relationships, that helps us in the emergency room, on the acute units, when we're doing consultations, when we're prescribing. So I want to emphasize that what we're talking about is not only an individual long-term psychotherapy, it's a way of thinking about self and other that can extend to all patient clinician interactions.
Thank you, Frank. I had you had mentioned that you and Diana had written a paper. Was that paper published yet? Was that paper published yet?
Oh, it's
could everybody mute themselves? Because I'm getting an echo.
Somebody named Amy needs to mute herself. Yeah, we're getting, yeah, the paper I'm talking about is actually part of a book. Routledge asked us to write a book about Otto Kernberg. It came out last year. It's called, what is it called? Otto Kernberg, A Contemporary Introduction. And in that book, there's a chapter that summarizes or actually expands on what I was just talking about.
Great. Maybe if when you have a minute, you might put the reference in the chat that people could.
Okay, I didn't want to do that. I thought it might be a conflict of interest, but I'll be happy.
No, it's perfectly okay. We're good. Okay. The other thought I just had just before I go to my next question was that there, in terms of what is and what is not psychoanalysis, that, the early founders of my institute, the William Alanson White Institute, like Frieda Fromm-Reichmann, and Harry Stack Sullivan, were people who worked with very, very disturbed patients. And then there would be these famous moments where, like, Frieda Fromm-Reichmann would present a case and everybody would say, well, that's all well and good, but it's not psychoanalysis. So I think that sort of picking up on the idea that the field has been drawn to, I think, obsessional neurotics, as a favorite kind of patient, and therefore has sort of avoided treating, a wider range of patients. And so, Donna, I see you shaking your head. You had a thought about that, or you have to unmute yourself.
One other thing that's really important to mention is that in these early studies that Kernberg did, and I think they started at the Menninger Foundation, they were very much not wanting to issue interpretation, transference work with borderline patients. And yet, the sort of growing wisdom was, no, these patients need a supportive treatment. They can't work in the transference. Interpretation, precipitates regression. And they actually did a study at Menninger which showed that with a proper structure and support and an interpretive process tailored for borderline patients, they actually did better in an interpretive approach. And now that's been taken up by Hoagland, our colleague in Norway, who has shown that actually transference work with disturbed patients who have disturbed object relations, he doesn't talk about borderline, but the more disturbed the object relations, the more they benefit from transference interpretation. So I think this is going against the grain of the thrust that's going on, that you can't treat disturbed patients analytically. And we believe you do with structure and support, and that's TFP.
Thank you. Any questions or comments from the audience? Because if not, I have other questions that I can ask. Okay, then I will go next then. So, you write in the chapter, this is from page 264, patients with pathological narcissism across the spectrum, the therapist must tolerate a sense of being devalued in the patient's experience and resist the impulse to respond reactively. Accepting criticism and being devalued is an important therapeutic intervention. It is what the patient cannot do since he or she feels any imperfection is tantamount to collapse. So my question is, How exactly do you learn to tolerate to be devalued by a patient? Are there specific techniques? Is it something any therapist can do?
Well, I can start with that. First of all, this is just part of the bread and butter of treating narcissistic patients. And I think if you understand that this is a form of resistance to the relationship, and that it's a way of distancing the self from the therapist, to devalue the therapist. Narcissistic patients are supremely, exquisitely sensitive to dependency and to help seeking. And even though they come into treatment, they're going to do everything they can to avoid that. So it's kind of a paradox, and you have to always be mindful of that paradox. Now, with that said, we have certain techniques that we work with. And one of them is using what Steiner calls therapist-centered interpretations. And this, we wrote about this in the chapter, but I'll just go over it really quickly. And this is where, when the patient is expressing particularly a lot of devaluing, angry feelings towards the therapist, and particularly when they're in an affectively heightened stage, that we don't make an interpretation that's an object relations interpretation. Like, for example, we wouldn't say, well, it's as though you're a deprived child and I'm an angry I'm a withholding, neglectful parent. That's not going to go anywhere with a narcissistic patient who's like in a devaluing state. Instead, we would say, it must be so difficult to have a therapist who can't give you what you need. And there's an example of this in the chapter. Or to have a therapist who cut you off at the end of the session. I think that's the example I give, and who couldn't hear what was most important to you. Okay, now we're saying that that's an empathic statement, but what we're really doing is defining the experience of the therapist or the other in the moment. And we're letting them know that we can tolerate how negatively they're seeing us. And we don't make any reference to their history or to their internal object world, or to their own motivations. And we sit with that. And at the same time, there's an art to it, because we're not acknowledging that we are that depriving, neglectful, et cetera, et cetera. We're just saying this is the way they're experiencing us in that moment. And then we work with that. And sometimes you have to do that many, many times, or you have to go back to it later in the treatment. But I think the most important way to deal with devaluation, then I'm going to turn this over to Frank, is experiencing it in the countertransference. We were supervising someone in our supervision group yesterday who was talking about feeling incredibly devalued and dismissed by the patient. And he clearly, it led to a little bit of a stalemate. He got frozen in the session. And it is like a stun gun, the devaluation. And it's kind of meant to be. Because these patients are very control conscious. They want control of the session. They want to reverse the tables. They want you to be in the humiliating position of being a patient, because that's how they feel. They feel it's humiliating. And so it's really important to sit with those feelings in the countertransference and think about, why would this be coming up now? What must the patient be experiencing? I know what I'm experiencing, and it's uncharacteristic of me. Is that a clue to what the patient is experiencing? So I wrote about this in the chapter where the patient comes in after we'd made an advance in the previous session, and he says he's going to quit. And I'm sitting there thinking, good riddance. Let's get this over with. This is a patient who'd been in a long analysis with a colleague who's a very good friend, very, very competent, but somewhat classical analyst. And I was thinking, what hubris to think I could treat this patient with TFP. And then I'm thinking, well, why? Why now? We just made an advance. And then I was thinking, okay, maybe that was difficult for him, right? He'd already come into treatment saying, I don't want to do a whole analysis again. I just want someone to hold my hand while I figure out whether I want to stay with this girlfriend, right? Already it's very devaluing. So I'm thinking, we made an advance and he couldn't tolerate it, and that was difficult. And in fact, that's what was going on. Anyway.
So you're giving a brilliant example of projective identification. That is, the patient put something into you, and it resonated with you in your own personal way. And until you sorted out what is me, first, then only could you then go to what might this be coming from the patient that provoked this response in me, correct? Would that be?
That's right. So we work very hard in the countertransference, but
Mhm.
without countertransference disclosure. So that's where we're a little different from some of the relational people.
I see.
We're always scanning and monitoring the countertransference. Well, I want to mention one other thing about the devaluation. It's related to dismissing attachment. So I also do a lot of work in attachment theory and research, and I've done some work with looking at the attachment status of the NPD, BPD, the narcissistic borderline patients in our randomized clinical trials of TFP.
Mhm.
And these are large-scale trials, and anything from 10 to 70% of our patients have combined NPD, BPD. And we found that those patients are more likely to have dismissing attachment than regular borderline patients without NPD. And if you know anything about dismissing attachment, these are people who have a cool, contemptuous attitude toward attachment figures. You know, they emphasize personal strengths and autonomy. So you can see that there's an overlap with narcissistic pathology, although dismissing attachment is not narcissistic pathology, but there's an overlap. So you put together dismissing attachment with narcissistic pathology, you're going to get devaluation. That's one of the primary defenses. So understanding these patients through the lens of attachment theory and research has helped me tremendously in my work with narcissistic patients. Okay, Frank, do you want to add to that?
I just wanted to add a little kind of take-home message about Jack's question, how do you deal with the devaluing? You have to constantly remind yourself of the dynamics of the narcissistic patient. What is the grandiosity about? It's a defense against feeling totally worthless, inadequate, insignificant, and that's a horribly painful internal state. So if you understand that that's at the core of the person, they can devalue you session after session. It can be irritating. You can have that hate in the countertransference. But if you keep saying to yourself, this is a defense, this is an attempt to escape from an intolerable internal state that I can eventually help them get in touch with, then you're more likely not to act out your countertransference by counterattacking or just kind of because research has shown that the two classic countertransferences to narcissistic patients are the therapist either counterattacks or just checks out mentally and is there in body, but sort of gives up on the person in mind, and acting out either of those countertransferences kills the therapy.
Thank you. John, hi, John. You have your hand up. Why don't you unmute yourself, introduce yourself, tell us where you're from. But I just want to, before you just store this question, Frank and Diana, the role of supervision, one's personal analysis related to the question just we had. John, go ahead.
Hi, I'm John Lavelle. I'm an analyst in New York City. My question is, what type of supports are you referring to that are required in order to do interpretive work with borderline and narcissistic patients?
Okay, well, I'm going to mention them really quickly, then I'm turning it over to Frank because he's the expert on the contract. The contract, number one, we work with a treatment contract. That gives support for the therapist and the patient in the treatment, giving them diagnosis or some semblance of their diagnosis, involving the family, the spouse, the partner, if necessary, at the beginning of treatment, so we get a sense of the totality of the patient's life. Now I'm going to turn it over to Frank because I think the main one is the contract. Frank.
Yeah, well, it's such a big issue, and it probably remains an issue in different psychoanalytic circles. One of our early books was about setting up the treatment contract. And just to give you an example of how controversial it was, many of you probably remember Herb Schlesinger, who was a great analyst and author, and he was one of our supervisors. He couldn't stand the concept of the contract. So what is the contract? It's the need to have an agreement with the patient about the conditions of treatment before you begin the treatment. It's a need to have a mutual understanding of the problem. Why do I say that? How many of our patients come in and say, I have a treatment-resistant depression. You see a personality disorder. As Diana said, You have to establish a common ground. We don't say, oh, look, you've got a borderline personality disorder, just look it up in DSM, or narcissistic personality disorder. We talk about a personality disorder in terms of the new favored understanding, difficulties in the sense of self and others. And that's what we'd like to focus on in the work. But here we get to the support through the contract. We would say things that you do make it difficult to explore parts of your mind. Our whole treatment is based on the idea that there are things within you of which you're not aware that have a big impact on how you feel, what you think, and what you do. And your lack of awareness isn't simply lack of knowledge. It's because awareness is disturbing, uncomfortable, and we're going to try to help you know those parts of yourself. In order to do that, we need to set up certain conditions, because look at your history. With a borderline patient, it might be cutting or overdosing. We say that interferes with the exploratory process. That short circuits the exploratory process. With a narcissistic patient, it might be doing things that are going to get them fired from a job, regular lateness, or using the office computer to look at pornography. So we say, in order to proceed, we have to have an understanding that you will refrain from these things to the best of your ability, so we can channel what gets discharged into those actions into feeling states that we have accessible to us here. I want to emphasize that some people say, when you set up these kind of conditions of treatment, some people say that's imposing something on the patient, that's asking more of the patient than they can do. But we see it as believing in the patient's potential. And we communicate this with the idea, we see your potential and we think you can get there if we agree upon these conditions of treatment.
I'm going to call on Yaya Davari in a second, but just one clarification. Could you distinguish between the frame and a contract, or how would you connect the two concepts?
The contract is the establishment of the frame. The contract process sets up the frame, so the frame is the result of the contract.
Oh, great, thank you. That's clear. Yeah, I hope I pronounced your name correctly. Could you unmute yourself and tell us where you're from?
Yeah, do you hear me?
Yes.
Yeah, I am Yahya Davari. I'm here today. I'm from Iran, and I assume you guys have heard the news about Iran today. And Dr. Yeomans, Dr. Diamond, this is an honor to be here today. And I would like to thank you for all you've done for the field of psychotherapy. We have limited access here in Iran to resources, but I have tried to dive into TFP through what is at my disposal, like books and YouTube videos. And I'm a psychologist, so I try to get into that and use it for my borderline patients. And I gotta say, that's wonderful. My question is that early Freud believed that narcissistic patients are not a good choice for analysis. Analysis will not work on them. What is different in TFP? As you mentioned, it's a type of analysis. What is different in TFP that you believed it will work on narcissistic patients? Thank you.
Okay, well, I'm going to start and then I'll turn it over to Frank. First of all, Freud didn't have a theory of pathological narcissism, and neither did Klein. They described patients who they, thought were narcissistic. But this is one of the areas in which Freud just sowed a seed. And then many people who came after him, I would say it's not until we get to Fairbairn, right? Fairbairn, the neo-Kleinians, that we really get a full-blown theory, and of course Kohut and Kernberg, that we get a full-blown theory of narcissism. So these people give homage to Freud, but Freud wasn't right about everything. Some of his work was rudimentary. And so I think, and Freud didn't understand attachment theory and research, right? So I think that this is an area that Bowlby came in well after Freud, but was very influenced by Freud and especially by Klein. So I think we can't say we have to say that Freud, I'm not going to say he was wrong, it's simply rudimentary, and he didn't have a theory of pathological narcissism. It was actually Wilhelm Reich with his work on character analysis that really first started talking about the narcissistic character. So, and how do you treat that character? And let's not forget that the going pathology of Freud's day was obsessional neurosis and hysteria and psychosis. Narcissistic personality disorder was not a factor in the general culture. The general culture was not a narcissistic culture that fosters narcissistic traits in its citizenry, which our culture does. So we could say that the focus on pathological narcissism and NPD really also come out of a cultural climate of the culture of narcissism, as Lasch said. Okay, that's a huge topic, and that's a very simplistic answer to a very complex question. But I'm going to say one thing about Iran specifically. First of all, it's wonderful to have you here. I hope your family and loved ones are okay. We're following the situation.
Thank you.
Very
Appreciate that.
stressed about this, I can tell you. But I do want to say that our book is being translated into Farsi by a group of psychologists in Iran who I have been in touch with and helped them with different aspects of the translation. And I find that
news.
It is wonderful news. The book is being translated actually into 8 languages, or has been. And it's very gratifying, particularly that it's being translated by certain countries like China, Russia, Iran, because there is a chapter on narcissism in leaders and groups. And I think that's very useful. And these psychologists have written to us and told us how valuable this book is for their work and their understanding of what's going on in their country. That's enough said about that. But I just wanted to let you know that. Okay, Frank, do you want to?
No, I think you did a good job with the question, but I just wanted to add that we could put you in touch with our colleagues in Iran who have been working on TFP. If you are not,
Good.
so just email me. You can find my email address online.
All right, thank you. But I just one thing is, so what Freud said about the narcissism did not have anything to do with their incapability of transference.
I'm sorry, I didn't quite hear the last
I
part.
think I got it. Yeah. The question was the Freud's not talking about this was not related to their incapacity to have a transference. But I just did want to say something about that because the lack of transference is the transference. Treating you like you're nothing is what a narcissist does. The first patient I treated with true narcissistic pathology, I would go to supervision with Otto Kernberg and say, I can't tell you what the transference is. I could just leave the room and it wouldn't make any difference. And Otto said, that is the transference. It's the total dismissiveness. So that's what you work with to start out.
Right.
Thank
And
you.
I think also maybe we're referring to, Freud, I think, talks about narcissistic transferences where his definition of a psychotic state, where the person was just, pushing all their libido toward the self. So I think that also creates some confusion in the language of Freud's time and the language of our time. We're really all not talking about the same thing. Thank you. Our next person up, forgive me, Purya Kamangar, could you unmute yourself and introduce yourself and tell us where you are?
Hello, I am Purya Kamangar. I'm from Kurdistan, Iran. I would like to thank IPA hosts and presenters. And my question is about the attachment that Dr. Diamond mentioned. I wanted to know that if there is any, the help that you are getting from the attachment theory into treating narcissistic patients and overall the patients, is it just about some conceptual understanding and getting help in that regard, or is there a technical implication from the technical interventions that attachment theory therapists do? Are we importing some of those techniques into TFP, or it's just about conceptual understanding? Thank you very much.
Well, it's a very interesting question, actually. And as someone who works both with TFP and personality disorders and attachment, it's one that I've thought a great deal about. And I would say it's both. conceptually, I didn't want to go into too long a thing about this, but, those with dismissing attachment have been found, even infants with dismissing attachment, by 1 year, they are, in the Ainsworth Strange situation, they are turning away. When the mother leaves the room, they don't make a fuss. When the mother comes back, they focus on their toys. They don't happily reunite with her. But they show great physiological reactivity, galvanic skin responses, heart rate increases. So even by 1 year, these dismissing defenses are in place. You see? Now, I think that helps tremendously with treating narcissistic patients, because I think about those with dismissing attachment as having two very different models. On the one hand, strong, self-sufficient, not needing others, and the other is not available emotionally. On the other hand, the self is rejected, neglected, and the other is neglecting. And when you observe mothers of kids who will go on to become dismissing, you observe those infants in the home before 1 year, the mother is seen to be rejecting and neglecting, turning away from the infant. So there is a kind of reality there. And I see that in narcissistic patients. When you get beyond the dismissing defenses, there is a profound neediness often. Some of these patients talk of that profound sense of annihilation and fear of abandonment. And some patients talk about it as the black hole in the self. So I would say, in terms of technique, it helps tremendously to know this is the way they attach in the beginning. It's dismissing. And that one has to analyze that and look for any, as Frank said, we look for breaks, what Lacan would have called the breaks in the unwinding of the conscious text. We look for indications of vulnerability, of need, and when that begins to change, which is a whole other issue. But so, yes, I would say it really affects how we experience the patients in the transference and the countertransference.
Just to add one thing, given what Diane is saying, the mid phase of therapy with a narcissistic patient, if therapy is working, is very difficult and very painful. And we have to expect that. We have to empathize with that. Patients come in when the grandiose self has stopped serving its defensive function, and when the person, maybe for the first time, is in touch with those incredibly intense longing for dependency, fear and anxiety about abandonment, feeling hatred and aggression, all of a sudden they're in touch with this cauldron that they haven't felt before. And they say, I don't know what's going on. I know this therapy is supposed to help, and maybe it is, but I feel worse. I feel worse than I've ever felt. I'm not exaggerating about it. I'm giving the most extreme cases. And we have to say, I understand that, but I hope you can trust what I'm saying. I think we have to go through this to get out and have you as well as you can be, because this is what we've been avoiding dealing with literally for your whole life. And if we can deal with it, come to terms with it, get to know it, and put it all together, I think you'll have a much fuller life.
Let me
Thank
just
you.
one thing to that, which I think is important, because Frank mentioned the mid phases. We talk about it as connection and retreat in the mid phases. So, often what happens is you think you've made a connection with the patient, things are going well. And then, as the patient I wrote about in this book chapter said to me at one point, I want to connect with you. I have so much to tell you. But then the metaphor he had for it was, he said, I go back to the halfway house where I can be in splendid isolation. That was a mental state that he had of retreat. So you expect these cycles of connection and retreat over and over again through the whole treatment, really until the latter phases.
Well, we have several people waiting to speak. Gunnar, I saw that you were first before, but now you're third. Did you go off and come? Would you like to go? Would you speak? And then Maya, I'll call on you next. Okay.
Yes, thank you very much. My name is Gunnar Riefschläger. I'm a therapist and analyst from Germany, and I have a very concrete question regarding the contract which was mentioned. And I wonder if it is an oral contract or if you would write down the contract, like in colleagues from CBT, they do this very often. And I wonder, how's the TFP approach? So what are the advantages or disadvantages of doing it, in this way, in an oral form or a written form?
It's an oral contract. We
Mhm.
enter into a discussion, we mark it, we say, I think I understand your difficulties and things about you well enough for us to discuss what treatment would be like if you're interested. And then you say, given X, well, first of all, you establish the basic frame of a psychoanalytic work. You talk about free association, you talk about the therapist role, including the limits of the therapist role, not giving advice, not, making recommendations, and so on and so forth. So you define the patient's role and your role. Then you might introduce specific parameters. You have an alcohol problem that would render any kind of therapeutic work useless. Will you agree to attend 12-step meetings and commit to sobriety if we work together? And you hope the person will agree. And even if they agree, of course, they might have slips, which you would analyze. But the point I'm trying to make in answer to your question is this is all a dialogue. And we do that for two reasons. If it were on a piece of paper, it would be much more impersonal. And people take a piece of paper and put it in their desk drawer and forget about it. We think that the discussion of the contract, which shows that you've thought a lot about the patient, you've thought about their problems, you've thought about how to address them effectively, that's the beginning of the internalization of a therapeutic alliance. And we feel it's more effective verbally than on a piece of paper.
Thank you.
Great. Mai Katab, could you introduce yourself? Tell us where you are.
Hello, hi. My name is May. I'm a consultant from Egypt, and I'm currently having my general adult psychiatry training in mostly London. I'm having special interest in analysis and dynamic therapy, and I have two questions. The first question is about it. Is Arabic language one of the 8 languages that the book is going to be translated to? The second question is about how a therapist be able to support a person who is in a relationship with a narcissist, either professional or family or romantic relationship. Thank you.
Those are very interesting questions. I'll start. No, Arabic is not one of the languages. If you know anybody in Egypt who would be interested, I can certainly put that person in touch with our publisher, with Guilford, and there's someone who deals with translations. I'm sorry, what was the second question? Oh, the second was, how do you support somebody who's in a relationship with a narcissist? This is an oft-asked question. There's no easy answer to that. Narcissistic patients have an incapacity to love in a reciprocal, mutual manner. They have their own way of loving. It's not that they don't love, but it's very using the other person as a sounding board, an extension of the self, a well of admiration to prop them up and keep them going. And partners get tired of that. And that's why many narcissistic individuals come into treatment in midlife or even later middle age when their partners have had enough, or their workmates or their children or their, whatever. So this is a complicated question, but I think narcissistic personality is unique among all the personality disorders in that it engenders distress in significant others, more than distress in the self. Now, with that said, distress is a characteristic of narcissistic personality. Someone did a survey of over 30,000 people who were high on NPD, and they did experience considerable distress. The first time I ever gave a talk, it was at a conference on the pain of narcissism. And if you go back to the original myth of Narcissus, this is a very painful story of a man who thinks he's falling in love with somebody else, that other person turns out to be himself, and then he's imprisoned. He's not able to love. He's not able to find the object. And what happens to him? he withers away and dies in one version of the myth, and the other, he actually stabs himself, commits suicide. That brings up a whole other issue about narcissistic patients that someone may want to ask about. But so the incapacity to love is a very painful state for many narcissistic patients. Often what we do in those situations is we recommend couples therapy, individual therapy for the partner to help them understand what's going on, and then couples therapy to, in the hopes that the narcissistic patient will thereby begin to look at themselves. But often, if they're unwilling to go to therapy themselves, then couples therapy is often a good way to start, even if the couples therapy is only a bridge to individual therapy.
If I
Anyway,
can, if I can add just a word, because it's a great question and Diana said a lot about it, but as you can all tell increasingly, I'm enamored of Melanie Klein's concepts of the paranoid schizoid organization and the depressive organization. And the person who's in love with a narcissist usually is stuck in their own paranoid schizoid organization because they fall for the seduction of the supposed ideal object. They take the narrative in. And so with that person, you might want to look for their difficulty in terms of their internal repertoire of internal object representations and how they're seeking something that doesn't exist, but the promise of which the narcissist offers. And you have to help them move from the paranoid schizoid organization with its promise of the ideal to the depressive organization, where you help them mourn the fact or mourn the possibility of finding the ideal in life in a person.
and another way to think about that is those with covert or vulnerable narcissism will sometimes seek out grandiose narcissists as partners. So that's often a pairing along with BPD and NPD. So usually when you start looking at those couples, the dynamics are very complicated. Think the movie The Wife, if any of you have seen it, about the woman who writes the books for her husband. And clearly she had a lot of narcissistic issues. She wasn't able to write her own books. So she ghost wrote the books for her husband, who got, I think it's when he gets the Nobel Prize, that the whole thing collapses. And she realizes the enormous, enormous price that she's paid for this and exposes him. Anyway.
Thank you. Thank you. Jonathan Sklar, could you unmute yourself? Tell us where you are.
Yes, good day. I'm an independent training analyst at the British Psychoanalytic Society. So I'm calling in from London, where it's a nice sunny day. I've enjoyed listening very much to this webinar. And I've got a question, and before you answer it, I'll say why I'm asking this question. Listening, it seems so obvious at times that the object who might be talked about would be a parent, a father or a mother. And I've heard all sorts of things spoken about as if it's the patient in their early history who created themselves in an alone narcissistic bubble. I enjoyed Kernberg very much in the mid-1970s. So I'm going back 50 years when I was training, until I reached a point in his writing where he was really for the patient. He worked extremely hard analytically, and at some point, he thought the patient would do best having a break in a mental hospital. And I didn't like that clinically. In part, I was being trained in a 5 times a week analysis and seeing my patients 5 times a week in the British tradition. And I thought that the capacity to hold the patient deeply when all else was failing was really rather important. And that's how I've followed my analytic work for the last 40 or more years. So when I hear about the neediness of the patient, the aloneness, the retreat, the incapacity to love and be loved, my mind, my analytic mind, my emotional mind turns quickly about, so what was the space that they grew up in? Were they loved? Were they held? Was there too much aggression between the parents projected onto the children? What about pedophilia, which is extremely common all around the world? So I'm not a Kleinian. I trained with John Steiner. I know a lot about it. Melanie Klein didn't have much time in her theory for history, but it seems to me that there's an obvious moment where the aloneness of the patient has something to do with not being invited in by the parent early on. And I'd be very interested in comments about that.
Well, I'll start. Yeah, by the way, it's wonderful to hear from someone in the British School, because I think if you've read our book or looked at our book, you know that the work of the British School, the Neo-Kleinians, and the independents figures very heavily in our thinking.
But they're both very different. They don't talk to each other in London.
I know. We talk to both of them in the book. We read both of them. I would say Steiner, Feldman, Symington. Symington, I think, was an independent, right?
Totally.
Yeah. Okay. They have really influenced our thinking, and Kernberg's thinking too. First of all, I couldn't agree with you more, and that's why I gave the example of the dismissing child, infant, and what people observe in the home. They observe parents who are rejecting, neglecting, not loving, and the child is protesting the way an avoidant, anxious child protests. But by the time they're 1 year old, that defensive system is already set in, and they turn away from the parent. And Symington, so I think that's it has to do with something that the parents are bringing. Now, I'm not going to reduce everything to, the child who's dismissing, the infant who's dismissing, because there's probably not a one-to-one correlation between dismissing attachment in infancy and the development of NPD. No one's done that research. I can tell you that Symington was very much onto this. And he said he has never treated a narcissistic patient when the individual didn't at some point turn away from the parent themselves and seek what he calls the narcissistic solution. And they do that in response to neglect or abuse. And there is research which does show that those who have NPD have higher levels of particularly emotional abuse in their histories, also physical and sexual abuse, but more emotional abuse. And I think that's really a fascinating finding. And yet they learn to deal with it in a somewhat different way. So not to get too technical, but we found in those studies that we did of the narcissistic versus the non-narcissistic borderlines, that the non-narcissistic borderlines were much more likely to have lack of resolution of trauma on the AI, whereas the narcissistic borderlines didn't have that. They had dismissing attachment style. They didn't have such
which is trauma.
Lack of resolution of trauma. Well, trauma would be sexual abuse,
No, but it would also be aloneness because the parents just don't do anything. That's massive trauma, I would say.
It is cumulative trauma.
Exactly. And transgenerational trauma as well.
It's cumulative trauma, and I would think of that as emotional abuse. So it's that kind of trauma that is more characteristic of narcissistic patients. Anyway, I'm glad you brought it up. It's a very important issue. And your group has made huge contributions to our thinking. I just want you to know that. Okay, Frank, do you want to add anything?
I agree with most of what's been said, but I just would simply add, and I notice the time is going and we have other questioners. Perhaps implicit in the comment was the idea of working with genetic interpretations, which we tend not to do, at least in the beginning and into the mid phase of treatment, because we find that that is an avoidance of the affect and the transference, because the transference isn't just the repetition of the past in the present, it's the activation of the patient's internal world of internal representations, which is related to the past, but which those representations are modified by affect, fears, anxieties, desires, fantasies. So if somebody comes in to my supervision and says, you know, my patient was experiencing me as totally unavailable, and I reminded them how, you know, their parent went off to study when they were 1 year old or 2 years old. I say, I think that's probably true, but I think it's far more important to work with how they're experiencing you now, because you have the affect and the ability to reflect on it simultaneously present.
Can I have one second just to respond?
We have a waiting list of 3 more people. Is that okay?
Okay.
I don't want to cut you off, Jonathan, but we really like to hear some other people as well. Okay, thank you for your comments and question.
Okay.
Carol, you're next. Could you tell us where you are and introduce yourself? You have to unmute yourself, though. No?
I think Carol disappeared.
Carol disappeared.
Hello, no, I'm here. Hello.
Okay, hi.
Hello, I'm Carol Elbaf. I'm from Lebanon. First of all, thank you. I want to thank you so much for your work. I feel grateful that I learned about TFP early in my career. It has been helping me a lot with my patients. And I want to ask a small practical question specifically with narcissistic patients. I want to ask about the frequency of the sessions, because in low-income countries like Lebanon, sometimes we work only one time with our patients. And sometimes I wonder if there's a threshold where we can say that this work cannot be done as at this frequency, in, specifically with narcissistic patients, because I wonder if a good transference work could develop at this frequency. Do we know about this? Do we have some information about 1 versus 2 sessions per week, specifically with narcissistic patients?
Frank, do you want to take that? Because you've
Well, okay, yeah, I mean, we teach a lot internationally, and in a lot of the places we teach, including the UK, where most people get therapy through the NHS, our students, and a lot of the students are rather senior people in the system, say, you know, in our NHS, we can't see people more than once a week. Same with our colleagues in Barcelona for the most part, and many other places in the world. So for years, we have worked with therapists who are limited to once a week, and our experience has been that it's harder for them, it puts more demands on them, it's not easy for the patient, but with a proper focus, you can help people with narcissistic personality disorder on a once weekly basis. But if it's any less frequent than that, I don't think there's any hope.
Thank you. We have another question. Carol, that's it. Does that answer your question?
Yeah.
Yes, thank you.
Okay, great. Okay. Ardalan, could you unmute yourself? Tell us where you are.
Hi, hello, Ardalan, a psychotherapist from Amsterdam. My question is, in your patient population, do you see any usefulness of Milan's subtype of the elitist narcissist, where it's not so much compensatory, but patients from wealthy, powerful families, where the fear is being average, not necessarily inferior, and who were raised like little princes, which is, you know, a form of neglect in itself. But what is your experience after 6 months, 1 year of TFP with this group, subgroup? Yeah.
Do you want to start, Frank, and I'll chime in?
Well, yeah, I would just sort of take issue with the concept, because we have a lot of patients like that from very well-off families, very highly successful families. And the problem that I see in most of them is they don't feel their value comes from themselves. They haven't developed that core sense of confidence in self, because so much has supported them externally, that I see the fundamental pathology as the same as most NPD patients, core doubt and feeling of inadequacy. So I don't think it's the fear of being average versus superior. I think it's the fear that I have all these superior trappings in my life, but I as an individual am empty.
Yes. And let me just add to that. We treat a lot of the kind of patient you're talking about. We do find that young adulthood is often a time when the pathology manifests itself. Now, it's complicated why that's the case. We know, for example, that in epidemiological studies, those who have high income, and we have this huge income discrepancy going on in the United States, many more of those individuals in young adulthood have narcissistic traits. So higher than what you find in the general population. So there's an epidemiological reality to this. On top of that, I think what happens with these individuals is they're treated like extensions of the parents, and they're expected to perform at a certain level, and they're given the idea that they can, and that they're owed certain things. And so they often can get through university, even graduate school, through helicopter parenting or an army of tutors who prop them up, right? Special classes, et cetera, or even if the parents are giving endowments to the schools, they get special treatment. But when they have to go out on their own and prove themselves, and they're expected to perform, often that's when there's a collapse. And they retreat to the parents' basement, attic, country house. They won't get a job. They won't function independently. And this can go on for years. We have patients referred to us in the Personality Disorders Institute who have lived like that for 5, sometimes even 10 years. And finally, the parents throw up their hands and say, the kid is 30 now. What are we going to do with them? They have the means to support them. But the person becomes more and more isolated, more and more encapsulated, more and more dysfunctional. So, as Frank said, this is a tremendously painful situation. So young adulthood is often a time of crisis and making one's way into the adult world. And if they have no economic necessity, you see, that often compounds the problem. And these patients can wind up in late midlife, never having worked, never having been out in the world, without friends, with the family the only source of social support or financial support. I don't know if that answers your question, but
Thank you very much. And so it remains very brittle, the self-image, despite all of it, very, very brittle.
Yes.
Kept together by these external forces, but superficially. Yeah. Okay.
Great.
Thank you.
We have one more hand up from Sil-Jun Lau. Could you tell us who you are, where you're from?
Thank you. My name is Sil-Jun Lau. I'm a psychiatrist calling from London in the United Kingdom. And my question is about practicing TFP or something like TFP in the National Health Service or the NHS. So as a psychiatrist in the NHS, which is the organisation which the vast majority of people here would access mental health care, in such an organisation, we try not to just think about the patient that's in front of us. We need to keep in mind the population in our local area that we're serving as well. And my question is about whether it's possible to take the insights and the benefits of TFPN, which I think probably helps us to understand the sort of burden of illness on our caseloads. For example, as has been mentioned, the treatment-resistant depressive. In a system where it's not pragmatic to train everyone in TFPN, is it possible to take what is good and beneficial about it and spread it in a system such as ours?
I think so. I think Anne Ward is on the call here. I don't want to put a pressure on you, Anne, but we've been working with a number of psychiatrists in the UK, including a group at the Maudsley, and I think they're attempting to do precisely what you're describing here to help, because it is a burden on therapists to have these extremely intense patients. And if a core group of those therapists understands the dynamics better, understands better how to deal with the countertransferences, it can diffuse pressure within the group. That's a short answer.
Yeah, can I add to that? Hi, Sil.
Hello, Anne, could you please, I'm sorry, we have somebody who has their hand up.
I'm sorry, Jack. I called on Anne. I
Oh,
called
okay.
on her because she
I
relates to
apologize.
the
Yeah.
question.
I just want to say Tennyson has written a book about this, and a book has come out, and I'll be very happy to share the chapters that I have with you.
Okay, thank you. If you could share
Wonder-
that, that'd be great.
Hello, Anne. So good to see you. I just can't resist saying one thing, which is that it's got to be 15 years ago that Anne contacted our group and said, help, in the NHS, we can only practice evidence-based treatments. Can you come over here and train us in TFP? Because some of us are analysts or analysts in training, and we don't want to only do CAT or MBT or whatever. And so Frank and I did spend a fair amount of time in London training a cadre. We called it our sleeper cell because for reasons I won't go into. But anyway, the end result is that Anne and a group of other people now run their own TFP center, and it is a treatment in the NHS. So I think that you've got a cadre of people there who could be advising you on this issue and how to help people understand the benefit of working more intensively with more disturbed personality disorder patients.
My apologies, Anne. And we have 5 minutes left. Agustin, if you could make it very quick, identify yourself, unmute, tell us where you are, and you have a minute to ask a question, and our discussants have 2 minutes to respond.
Yes, thank you. I am Agustin Smelowski from Hungary, the training analyst. And my question is about indication. So if we put aside the external factors as just focusing on a personality level, so what do you think, or your experience, when the TFP is better for a personality disorder person and when a standard analysis is better? Thank you.
Why don't you take that one?
You want me to take that one?
Yeah.
You know, I wish I could give you an easy answer, but I don't think I have one, unfortunately, because there's certain things I could say that we look for. We look for psychological mindedness, the capacity for mentalization, some capacity for, that is, reflection. We look for some premorbid accomplishment. Like, is this somebody who's shown some capacity for sublimation? Have they gotten through, for example, even a year of college? Do they have aspirations, and so on and so forth? You know, so I think, and one of the things I like about what's going on in the UK and has gone on in the UK for many, many years at the British Institute is many more very disturbed patients are in analysis as opposed to TFP or psychoanalytic psychotherapy or DBT than in the United States. And there are a lot of, I think, sociological reasons for that. But the bottom line is, I think some of these patients can be successfully treated in analysis. I think a not too absolutely shattering history of trauma. I think the patients who have had the most severe trauma, although we've treated some of them in TFP very successfully, including patients with malignant narcissism, but those patients probably are better suited for TFP than for analysis. They may not have the ego strength to do analysis yet. So that's the best answer I can give you. Do you want to add anything, Frank?
Just want to say, I do want to contradict you at one point. You say we look for psychological mindedness and some capacity for reflection, but our research has shown that we can treat patients with zero capacity for reflection, with zero reflective functioning, and that we did better than DBT or supportive psychodynamic therapy with the people who didn't have any capacity for reflection. And we think it's because the work, in essence, is very concrete. It's like, what's happening right here in this room? It's not abstract. It's the opposite of abstract.
Yes, but
very interpersonal. Diana, last word, and then we're going to have to wrap up.
We also know that if you start out TFP with a higher level of capacity for mentalization, you do better, and your mentalization improves more. So that's why I was saying, and what I meant is those patients may be able to be in analysis.
Oh.
As well as TFP. So, okay. Thank you.
I wanted to thank you both. Really, you were great. I wanted to thank the audience for your participation as well. A round of applause for Doctors Diamond and Yeomans, if we might. I was seeing maybe we could have our final slides. So just so you know, the IPA is having a webinar in 2 weeks on June 27th at 4 p.m. London time. That would be 11 a.m. New York Eastern time in the US. Is trauma still a key concept in psychoanalysis? This is a dialogue with Steve Seligman. But Dr. Seligman, I know, is giving an IPA plenary address at in Lisbon in July. I'm looking forward to that. And then the next slide is, so this is our schedule for the journal clubs. We're taking a summer break. Our next meeting will be on September 26th with Dion Powell. Not clear what she's talking about. We're going to have Ann Durkol, Salman Akhtar, Victoria Linjardi, and Nancy McWilliams talking about the PDM-3, which is coming out soon. Austin Ratner talking about the psychoanalyst's aversion to proof. And finally, next year, Beatrice Beebe, we're going to have an interesting journal club. We're going to watch a video rather than do a book chapter. You can turn off the slides now. And again, thank you everybody very much. Thank you for coming. Really great.
Thank you, Jack. Great.
So much, Jack, for inviting us. And
Of
the
course.
audience. Thank you.
Yeah. Bye-bye.
Bye.
Bye-bye.